So hello everyone, in this video we will discuss the fetal circulation. The fetus circulatory system differentiates from the mesoderm of the embryo. And when does the fetal heart begins to beat? It is around 4th week of gestation. The major difference between the circulatory system of the fetus and that of the adult is the presence of placenta. The placenta is the connection between the mother and the fetus. The placenta performs the function of 4 organs in the fetus, namely the lungs. So the placenta is doing the gas exchange. The placenta is providing nutrition. It is GIT for the fetus. The placenta is also liver of the fetus. It is helping in nutrition and waste removal. The placenta is maintaining the fluid and electrolyte balance in removal of the toxins and the waste. So it is kidneys for the fetus. Therefore, the fetal heart pumps a larger quantity of blood through the placenta and lesser amounts through the other organs. The key principle governing the unique pattern of the blood flow in the fetus is that there are 4 major shunts present. Shunts are the pathways that allow blood to bypass the future postnatal route. The right and the left side of the fetal heart, they pump in parallel and not in series. So the input and output of the right and the left heart will mix up. That will be combined cardiac output. That will be cardiac output of the right side and the cardiac output of the left side. You combine them. So the 4 major shunts in the fetus are, firstly, the placenta itself. Secondly, we have foramen ovale, that is opening between the right atrium and the left atrium. This one is present in the interatrial septum. We have ductus arteriosus, that is a connection between the pulmonary artery and the aorta. And the patency of ductus arteriosus is because of the mediator PGE2, prostaglandin A2. In fact, if it does not constrict on birth, you can use the PGE2 inhibitors to constrict it. Fourth one is the ductus venosus. Bypasses the liver, it allows blood from the umbilical vein to enter the inferior vena cava directly. So fetal circulation, there are 2 umbilical arteries and 1 umbilical vein. And here the arteries are carrying de-oxygenated blood. So this is an exception. Usually arteries carry oxygenated blood. But the 2 umbilical arteries, they return the de-oxygenated blood, the fecal waste and the carbon dioxide to the placenta. And there is 1 umbilical vein that is going to bring the oxygenated blood and nutrients to the fetus. So you must appreciate the beautiful design of the fetal circulation. It's very interesting how it operates. We'll start from the bottom, from placenta. Can you see this arrow? So the umbilical vein, they carry oxygenated blood from the placenta. And this blood is 80% saturated with oxygen. Why not 100%? Because some of the blood placenta has already used for its nourishment. As simple as that. So 80% saturation. So umbilical vein going into the liver, and then you can see the portal vein also entering the liver. The portal vein gives a branch portal sinus, and the umbilical vein and the portal sinus combine. Ductus venosus is formed. From ductus venosus, the blood will drain into inferior vena cava. From inferior vena cava, the blood will drain into right atrium. Now what would be the fate of this blood? Right atrium to left atrium through the patent foramen ovale. And from left atrium to left ventricle, then through aorta, elsewhere to the body. In addition to this, we have the blood that is coming from the head and the upper extremities through superior vena cava to the right atrium. And we have the blood that is coming from the abdomen and the lower extremities to the right atrium. So this blood will go from right atrium to right ventricle, from right ventricle to pulmonary artery, and from pulmonary artery to, can you guess? There is ductus arteriosus. So from pulmonary artery to aorta. So there is a mixing of blood. Okay, oxygenated and deoxygenated blood, they are mixing together. There is progressive dilution of the well-oxygenated blood with the deoxygenated blood. Right? And if you consider the partial pressure of oxygen, you'll see that in umbilical vein we said 80% saturated with oxygen. But by the time this blood reaches the heart and the head, it is 62% saturated. The lungs are getting just 52%. So that means that is as you're coming down, the circulation, there is drop in the levels of PO2. So umbilical vein, we say, has 80% saturation, not 100%, because 20% placenta has already used the oxygen. Now liver is also getting the blood supply from the portal vein, and portal vein has oxygen saturation 27%, and there is addition of blood from the inferior vena cava, that is 26% saturation. So this 80% saturation will fall to 67. The blood going to the right atrium is 67% saturated. That is further joined by blood from superior vena cava and the coronary sinus, that is 25% saturated. So this blood goes from the right atrium to the lungs. Lungs 52% saturation goes, and then from right atrium you have foramen ovale. Some of the blood goes to the left side. Left atrium is also joined by a little amount of blood from the pulmonary vein, that has 42% saturation. So now in the left atrium it becomes 62%. So that means what is going to the heart and the head is 62%, and what is going to lungs is 52%. What is going to ductus arteriosus and descending aorta 58%. So we started from the 80%. Now see, it is 62, 58, 52. So there is dilution of the well oxygenated blood. So this is what the tissues are receiving. But you know, the fetal hemoglobin is different from the adult hemoglobin. It has high affinity for oxygen, right? So it can manage. Peculiarities of the fetal circulation. The two ventricles of the fetal heart are much of the same size. Both the right and the left, they are much of the same size. And very little right ventricular output pumps through the lung, as the lungs, they are collapsed. And the vascular resistance is very high. Okay? Most of the blood is going to the placenta. The fetal ventricle, we said, are working parallel because we ductus arteriosus and foramen ovale are patent. Mean arterial pressure at birth is 55 millimeters mercury. In the adult, it is 100 millimeter mercury. So when does it become double? During the last months of gestation, last months of pregnancy, and fetal heart rate also declines during this time. Initially, the heart rate is very high. How? Because of development of the cardiovascular control by the autonomic nervous system, and there is establishment of the baroreceptor reflexes during the last months of gestation. Now what happens at the time of the birth? At the time of the birth, there are three different metabolic derangements that the fetus has to undergo. One is that he faces hypoxia because you have cut the placental supply. Okay. Then there is hypoglycemia, the nutrient has gone as the umbilical cord is clamped, the placental circulation is cut. Then there is hypothermia because initially the baby was in a warm environment, the mother's cocoon, and now the environment is very cold outside. Okay, so the baby is feeling the difference, and these three major changes will lead to the a trigger that will cause the shifting from the fetal circulation to the adult circulation. And I would like to add a note on placental transfusion. What is the significance of placental transfusion? When the cord is clamped, additional 75 to 100 ml of the blood preferentially flows towards the fetus. So fetus gets this blood. Even when you clamp the cord, so this amount of blood goes to the fetus. The total volume of the blood is 300 ml in the fetus. And at the time of the delivery, when the cord is clamped, it takes 75 to 100 ml. So that is a good thing. That blood is not wasted. It is coming towards the placenta. Through the placenta, it's coming towards the baby. So that's good. Placental transfusion. Now, what are the cardiopulmonary adjustments in the fetal circulation at birth? As the newborn exits the birth canal, it takes its first breath, and that breath will expand the lungs and trigger a series of changes in the circulatory system. Right? So at birth, the umbilical cord is clamped. So there is no placental circulation now. That means fetus has to breathe through its own lung. The infant will become asphyxiated. Asphyxia is a combination of hypoxia and hypercarbia. The infant will start gasping, breathe with open mouth, attempts to breathe. This generates a respiratory signal and activates the respiratory center. The lungs get expanded, the intrapleural pressure drops, becomes negative. As the lungs fill with air, pulmonary vascular resistance falls and the pulmonary blood flow increases. Now there is blood that is coming in the left atrium from the pulmonary veins also. So the pressure in the left atrium will rise. That will become more than the right atrium. That will close the foramen ovale. The pressure in aorta will now rise and keep on rising until it exceeds the pulmonary artery. So this is called reversal of flow, because initially we said through ductus arteriosus, the blood was going from the pulmonary artery to the aorta. This is reversal. And the ductus arteriosus will begin to close within few minutes, though the full functional closure may take about 24 to 48 hours. Now what happens if the fetal circulation persists? Adult circulation didn't come. What will happen? Does it happen? Yes, in some cases it is seen. 8% of the congenital heart disease constitutes of patent ductus arteriosus and patent foramen ovale. Okay, patent foramen ovale is also known as atrial septal defect, because both the atria are still communicating with one another. So what will happen? As a result of this, there will be mixing of oxygen rich and oxygen poor blood. So blood reaching the tissues will not be fully oxygenated. That will cause cyanosis. We have another thing called as Fallot's tetralogy, 4 defects, namely VSD, ventricular septal defect, pulmonary stenosis, the right ventricular hypertrophy, and overriding aorta, that is misplaced aorta. Okay, here the aorta is above the ventriculum septum defect instead of being over the left side. So it's on the VSD. So this is when the fetal circulation persists and the fetus is suffering from some congenital heart diseases. A newborn's first cry is a sign that lungs are healthy. That's why the physicians, everyone wants that the baby should cry. So that is an indicator that the lungs are fit. So what makes the baby cry? It is exposure to the cold air and the new environment outside. The crying will expand the lungs and expel the amniotic fluid in the mucus. And what if the crying is delayed? It isn't necessarily a cause of worry. You should see the color of the baby. Many babies are healthy, pink, quite alert, they're doing the limb movements, and they'll start crying. Though a few minutes later, that's normal. And when the fetus is not breathing immediately after birth, there will be hypoxia and hypercapnia. That is, again, an additional stimulus to the respiratory center to breathe. So, the child will cry. The doctor may do the suction cleaning of the nostrils or pat the baby on the sole. That is providing a tactile stimulation for breathing. Okay, but still, if many minutes have passed and the baby didn't cry, then you have to see the Apgar score, activity of the baby, the pulse, the respiratory rate, okay, the reflexes, the tone, the grimace, the facial expressions, and the reflexes. So you have to see, and then you have to make the Apgar score and see if the baby requires emergency medical intervention. So thank you. Happy learning. Hope this was useful to you.